Hey there, hello. This is neuropsychologist Dr. Karen Sullivan, and we are doing something a little bit different tonight. We are going to do a live question and answer session because so many of you write me and I don't have the time to write back. So often your questions lead to the lectures that we offer every Wednesday at 6 o'clock, but sometimes the questions you have are I'm able to answer them within just a couple of minutes. And so that's what we're gonna do tonight. This specific session was inspired by a question that I got from our buddy, good old Jerry. Oh, hey, Dahlia. That's a really fun thing too about this question and answer is I can actually respond to the questions that I see. Dahlia, you have a name that is very near and dear to me. There's my friend Jerry. So Jerry sent me a question asking, what should I do as a family member if I'm worried that someone in the family is developing dementia? And that is such an important question that I thought, let's just turn this into a live session where we can get more info and go back and forth. So the most important thing is that you're noticing, that you care. That's fantastic. So what I want people to notice right off the bat is if their loved one's symptoms or signs fall into one of two categories. The first one is if things have been happening slowly and gradually. The other one is if things have been happening very quickly and all of a sudden the person is like not themselves and just seems to be really having a rapid decline. That second one, the rapid decline, is something that really needs to prompt you into action. What you could do there is get in touch with their primary care doctor, take them to the emergency room. Oftentimes, those are signs of more urgent, pressing neurological change. Some things like infections, encephalopathy, stroke, of course, we know how important that is to act quickly. In those cases, you really want to get someone to medical attention because it's something that could be getting exceedingly worse in a short amount of time and it could be life-threatening. So we really want people to treat that like an emergency. So many other instances of dementia go in the slow and gradual category. And in that instance, you have a lot more time to react and you can get a little bit more systematic about your observations. So you could start to notice, how many times are they asking you the same question? Does it seem to be happening when they're very anxious? Does it seem to be happening when they're telling you they're not sleeping very well? There are really important things to look out for in terms of everyday functioning, and that's really where your attention should go because you can't have a condition like dementia if things in everyday life are going perfectly normal and the person is able to maintain their activities of daily living independently and without support. So if you follow me, you know that we talk about these things often. And the most complex thing we evaluate as neuropsychologists is financial management. And tax season just having been behind us here in the United States, this was a great opportunity to observe someone's organization, their memory for remembering the things they need to gather, who they should bring it to. And the next one under that is remembering medicines and then driving. Those two are about equal. So if someone is really struggling cognitively, it will show up in that area. So Jerry just added, she says nothing is wrong. So that, I'll pause right there. Oftentimes people's insight into what's going on with them is an important factor, and that's something we do evaluate when you come to see a neuropsychologist. And there's really two things that could be going on there. It's very easy to feel like that could be a psychological defense, that they're in denial, but oftentimes it's actually part of the neurological syndrome that's happening to the person. And so, for example, in Alzheimer's disease, that is one of the symptoms, especially as the disease is progressing, that people have an inability to have insight into what's changing about them. The other thing we always have to keep in mind is that there is a huge amount of stigma in society about people who aren't all there, have lost their minds, have dementia, whatever all those stereotypes are. And we've internalized that as people. It's a huge fear of all people to have a cognitive impairment. So it's understandable that people might want to dig their heels in and avoid it. Unfortunately, nowadays, you really pay a price for delaying neuropsychological evaluations if there is a cause identified that can be helped with the memory medications that are on the market. Many times, I was just telling this to a patient today who was pretty fearful about the evaluation. And I really want people to feel empowered by these evaluations, because it really goes one of two ways. You know, worst case scenario, if there's something progressive and degenerative like a dementia that's happening, it does us no good to ignore it, and we kind of have to call a spade a spade. And the earlier we know, the earlier we can start the treatments that are available today, and they slow down the progression of the symptoms, or at least stabilize them. So you're in a much better position coming in earlier rather than later. Number two, the alternative is that we find things that are treatable, things that are reversible. I have many, many patients who I've seen over the last 10 years of practicing who are taking a medicine that's slowing them down mentally, that actually have multiple urinary tract infections and they can't get out of that state of confusion. There's some people who, I just had this case recently, a woman who was significantly hard of hearing and wasn't wearing her hearing aids, and she just couldn't hear what was going on, so she couldn't make the memory. So that is a good rationale. The other thing is, if you can't convince the person to do it for themselves, Jerry, sometimes you can just say, you know, look, I'm your daughter. I'm so worried about what's going on with you. Like, go and do it for me. I have also had instances in the last 10 years where people's daughters, their best friends have brought them to me, and it's not exactly been on the up and up. I've had people who said, I just met this very nice woman and I want you to go talk to her. Other people who get the person in the room and say, look, it's almost like an intervention. Like, I'm worried, these are the reasons. So when you come into the doctor's office, it's really good, of course, to always be respectful and just emphasize, this is my opinion, but I feel like I really need a professional to come in and do this evaluation. Also really important to have examples ready, right? Because what happens is it very easily becomes kind of a point of tension between people. People can feel picked on. They feel like you're giving them a hard time. And so it's really important when you work with a neuropsychologist that you're able to go back to being family and not necessarily like reporter. So finding a neuropsychologist that you can work with that approaches it in a very respectful, fair way. I often start my evaluations by saying, I am not looking for any problems here. We're not going to make a mountain out of a molehill. We're going to be very thorough. And if something is going on, we're going to identify it so we have more control over it. You know, maybe, Jerry, you can get her to watch some of my videos that just talk a little bit about memory loss, what's normal, what's not normal as we age, to at least start to have a conversation about it. And, you know, of course, you guys can send us your zip codes and we will help you find a board certified neuropsychologist in your area. There was a woman on our Facebook page who posted a question to the graphic of the Q&A for tonight, and she was asking me about childhood onset essential tremor. And so I just wanted to answer that question quickly. We do address that in the Essential Tremor webinar that we have 4 hours of really good information about the neurological side, the psychological side, the neuropsychological side of ET, and we talk about genetics and age of onset. And so from that webinar, I can tell you that the earlier someone has ET, unfortunately, the more severe it gets over time. And that's kind of a golden rule in neuropsychology and neurology in general, is that if someone, the earlier someone is, as they develop their neurological issues, the more genetic it is. So we have a lot of instances like that in the difference between late onset Alzheimer's and early onset. Folks who get the early onset before the age of 60, 65 have much stronger genetics for developing that disease. A lot of dementias later in life are a combination of a genetic predisposition, but something in the environment, the person's lifestyle, that unfortunately turns on those genes. And that's a lot of what we've been focusing on in the I Care for Your Brain School. We talk a lot about what we call modifiable risk factors. What are those keys that turn on those locks? Because all of us want to stay as intact as we possibly can be. Another question that had come up earlier, I think, was about transcranial magnetic stimulation. And I have been a big proponent of that when it's used properly in a scientific setting with clinicians who know what they're doing. The idea is that you're basically providing electrical stimulation to the brain, going through the skull with strong electric waves, in order to get more output or more activity from different parts of the brain. Typically, it's used clinically in mood disorders like depression. But also, it's funny, just this morning I was watching some lectures from the American Academy of Clinical Neuropsychology conference that is virtual this year, but just came out live a few days ago with recordings. And one of the lectures that I watched was about the cerebellum, which a lot of you guys know is one of my favorite things to talk about. And the researcher, was talking about the fact that they had done some TMS on people who had cerebellar strokes, and they were getting really good outcome. So I think the idea is now it's changing more from just something for mental health, and it's getting a little bit more into things like traumatic brain injury. But I support it in general because it has a really good evidence base. You know, that's one of the reasons I started doing these lectures 4 years ago, is because I wanted you all to have a reliable, trustworthy, science-based place to get your information. There's too many scams, supplements, clinics that pop up for the brain health community because y'all are desperate to get better, to get well, to feel better, and people know that. And so unfortunately, there's a lot of money makers out there that I don't approve of, but and I think people can run wild with TMS, but typically if you look at the research literature, it is supported. Hopefully we're getting more and more insurance companies to pay for it. I know when we had TMS in our community, you had to have a psychiatrist approve it, and then Medicare was able to cover it. Okay, Angela's going to keep me going with the cerebellum, and then Miss Barbara, of course. Okay, so how about cerebellar vertigo issues? Yeah, the cerebellum is like the great coordinator in the brain, so it coordinates everything. Eye movements, the way we move our hands, the way we coordinate our thoughts, the way our emotions come together. So with vertigo, a lot of times it is an overall issue with eye movements and just like what we call proprioception, so knowing where exactly our body is in space. Vertigo issues, though, it's very important to have them evaluated because they can be coming from a variety of different issues, and it's really important to pinpoint where they're coming from, and that way you know what specific treatments you should get. It sounds like maybe you already know it's coming from your cerebellum, and so I knew this already about the cerebellum, but I was reminded during this lecture I watched today that the cerebellum has more brain cells, neurons in it, than any other part of the brain. About 70 to 80% of the whole brain cells are in the cerebellum. It is extremely myelinated. There's a ton of white matter in there, which really speaks to its purpose, which is to coordinate things extremely quickly. So there's so many things we do so quickly, in fact, that they're unconscious. Moving your eyes is one of those in particular. And so there's so many teeny tiny little subtle things that can change the way we feel in space, and that can cause some of the symptoms of vertigo. I would recommend, Angela, you try to go to a neuro-ophthalmologist. Now, you think finding a neuropsychologist is looking for a needle in a haystack. Neuro-ophthalmologists are even more rare, but what is so important about what they offer you is if you're having any kind of eye movement issue that's causing symptoms that is not happening at the level of the eyeball, but is happening at the level of the brain, they're able to separate the two, and they can recommend rehab exercises specifically for your cerebellum. So that is super important. Now, let me see if I can go back up here and see what wonderful Barbara asked me. Barbara said, ET started with me as a result of the cerebellar stroke. Does it stop, or does ET just continue? So Barbara, I would say, and this is funny because I'm not just talking as a doctor on Facebook, but you and I know each other. What I would say is I don't think you necessarily have essential tremor, because it wouldn't be as a result of a cerebellar stroke. You could have it, but it would be co-occurring. Or it could be that you have tremor because of your stroke and it kind of looks like ET. And so unfortunately, it is something that goes along with having a cerebellar stroke. You can make sure you do things to minimize it. We know that stress really exacerbates it. We know that over time alcohol makes it a little bit worse, makes it a little better in the short term, probably makes it a little bit worse in the long term. But that's something that would be important to take back to the neurologist, maybe even try to see a movement disorder specialist and they could help you tease apart tremor from cerebellar issues versus tremor from ET, which also is related to cerebellar issues, but isn't an acute injury like a stroke. Okay. You guys are all so sweet out there in the Facebook world. Okay, Miss Vanessa. Starting to notice increasing neuro issues, ongoing internal tremors. That's a really tough one to get people to understand. Balance, brain fog, fatigue, but neurologist isn't taking it serious. Tips on how to deal with dismissive doctors. This is such an important issue. Oh, goodness gracious. My first thought is find other neurologists, find one that doesn't ascribe to the philosophy that the neurologist is here and the patient is here. Unfortunately, that's much too common of an approach to patient care, finding someone that really wants to partner with you. I think sometimes you have to think about why did people go into certain branches of medicine. Some neurologists are just very like in the box and very interested in objective test scores, not so interested in subjective experience. This is one of the reasons I really think neuropsychologists are a great care partner for the brain health community, because you get validated on both sides. You could have a mental health issue that's causing the majority of these issues, but it also could be something else. And so you need someone who doesn't feel like the mental health issues are here and a neuro issue is here. What we know is that they're all the same and they're all valid and they're all important to explore and consider. Sometimes people bypass neurologists and go right to a neuropsychologist, and so maybe that would be something for you. If you send us a message with your zip code, we'll be happy to send you a name of closest best person to you. Oh, there's my other Sullivan, Ellie Sullivan. How are you doing? All right. Mr. Steven, who's such a nice supporter of us. He says, I was never afraid of heights pre-stroke. Even now, a picture from a high elevation makes me dizzy. Has even found its way into my dreams. Wow. So many different things. I mean, I always run the brain through this idea of evolution, which is so many of the things that we experience are a reaction of adaptive strategies and behaviors that have had to develop over the time of evolution. So a lot of things are really to protect us. And so I wonder if maybe on a psychological level, the height just represents a threat or something that's kind of a danger to you. And I wonder if maybe broadly speaking, if you have more kind of sensitivity to threat in your life. It could also be that, you know, there's a lot about the brain we don't really know. Is there a part of the brain that helps us process heights? Probably, that could very well be. And could it possibly be that your stroke kind of hit you right there in that sweet spot? Could certainly be. I think as a psychologist, I kind of think a little bit more symbolically about symptoms. So I would say one of those two things, but also really interesting to like write down your dreams and, you know, explore their meanings. There's a really great podcast called This Jungian Life that I adore, Jungian. And at the end of every podcast, which is they basically talk about a subject using the lens of Carl Jungian psychology, they interpret a dream. And it's amazing the things that they come up with from the dreams that people write into their show. You just learn so much. It's really, really, really fascinating. Okay, Paula. Can pain cause tremor? I am not convinced tremors are ET. So first thing I would say, Paula, is get yourself to a really good movement disorder specialist, because they are so skilled at teasing apart. I mean, tremor is a huge umbrella category, and so you need someone who understands the difference between a ET tremor versus a Parkinson's tremor versus a tremor caused from some other reason. Can pain cause tremor? That's a really interesting question. I mean, if you think about images we all have in our mind of people that have been in a lot of pain, you do have this feeling where they're just kind of almost shivering and shaking. So the question is, like, is that a tremor? Tremor we typically think of as involuntary, or that's when it kind of can become like a functional tremor, where it's not just something purely neurological, that it's something more related to like not so great coping skills or stress or anxiety, something like that. You could have a neurological issue that causes both pain and tremor. So anything in the subcortical part of the brain. So I'm thinking about like thalamus, basal ganglia. You could have two disorders in the brain that kind of overlap, or when they happen, they feel related. So you can have a pain syndrome and you can maybe have tremors from something that's going on in the brain. But a good movement disorder specialist would be really, really helpful. Okay, let me just see. Stephen, Jerry's got some advice for you. You better listen to Jerry. He's an expert. Okay, somebody else had emailed us asking how the brain school was going, and it's been amazing. We have had 2 sessions so far, and we've had people from all over the world, all over the US, and it's just really been a fantastic experience for me so far. We thought that the lecture and the Q&A would take about 90 minutes, but for each 2 lectures, it's been right at about 2 hours. So that gives you a sense of like how much we're learning together and how much of a good time we're having. Lecture 3 is Heart Health Equals Brain Health. And in mid-June, we're going to be doing that. So I know somewhere in the comments here, we'll be posting a link so you all can sign up. It's limited audience. And so if you want your seat, you got to get in there and get it soon. So in the future, I will be doing more of these Q&As. I think that this is really fun. This is a really awesome way to get to connect. And I hope that I was able to get to your question tonight. If not, I'll definitely try to do this again soon. I will not be here for your brain health lecture next Wednesday because I am going to be on vacation. And I am very much excited to take some time and decompress a little bit. I think time away is a really important thing. Oh, look at all those hearts. You guys are so sweet. I really appreciate this time together. I look forward to it all week, and all of you out there trying so hard to educate and empower yourselves about your brain health condition or a loved one. I think there's nothing better that you could be doing for yourself every time you listen to a lecture like this or come with us at Brain School. It's really an act of self-care. I really believe that. And that's a huge, thank you, Salud. That's a really important part of taking care of yourself is telling yourself that you matter and you need to do the things that are going to make you feel better. You guys are all so sweet. I look forward to the vacation. We're going to the beach, and this is a beach we've been going to every year since we moved to North Carolina about 8 years ago. So I'm really looking forward to it, and I'm excited to come back after with some new ideas. Please don't hesitate to send us a little message in Facebook and let us know what you want to hear. Thank you guys so much, and I'll see you soon. Bye-bye.